Hello everyone, welcome back. Today I'll be covering my note, journal number 3, Review Article of Management of Tuberculosis Infection of the Spine by Pankaj et al. From ASEAN Spine Journal 2016. Now let's get started. Introduction. Spinal tuberculosis (TB) is primarily a medical disease and anti-tubercular treatment (ATT) is the mainstay of treatment. Conventional medical treatment of spinal tuberculosis ranges from 18 to 24 months. Although the WHO recommends that pulmonary and extrapulmonary TB should be treated based on 6 months of rifampicin, 2 months isoniazid, rifampicin, pyrazinamide, ethambutol, plus 4 months of isoniazid and rifampicin, other experts recommend treatment for 9 months to 12 months because of the difficulty in assessing the treatment response. Indication for surgical intervention. Number 1, patients with neurological deficit. 2, potential mechanical instability. 3, kyphosis leading to sagittal imbalance. 4, for tissue diagnosis in cases of doubtful diagnosis. Number 5, drainage of an abscess that compresses the spinal cord that impairs the patient condition, example, causing difficulty in breathing in cervical abscess. Number 6, evacuation of a large paravertebral abscess showing marked increase in size despite on anti-TB treatment for more than 3 months. This is via MRI findings. Number 7, neural complications that have not responded to drug therapy, that means failed conservative management. Number 8, deteriorating neurology despite anti-tuberculous therapy. Number 9, recurrence of neural complication. Number 10, presence of severe kyphosis more than 60 degrees or if the kyphosis is likely to heal with this amount of deformity. Special case in children. Number 11, younger than 7 years of age. Number 12, 3 or more affected vertebral bodies in the dorsal or dorsolumbar spine. Number 13, 2 or more at-risk signs that are likely to have progression of the kyphosis with growth. This should undergo correction and fusion. As a revision, this figure shows spine at-risk radiological signs. Number A, separation of the facet joint or facet subluxation. B, retropulsion. C, lateral translation. D, toppling. Question. Safety of implant usage in spinal TB case. Oga et al. Reported that, unlike Staphylococcus aureus, Mycobacterium species do not form extensive biofilms. Thus, the use of an implant in the setting of a spine tuberculosis infection is not a hazard when combined with intensive anti-tuberculous chemotherapy. What are the indications for instrumentation? When the spinal column has been rendered unstable in the process of surgical debridement or decompression. When the correction of the deformity is anticipated, or when the aim is to prevent progression of kyphosis. This figure shows the kyphotic deformity at the thoracolumbar junction. For anterior instrumentation, spinal tuberculosis is predominantly an anterior disease. cord compression by granulation tissue, caseous material, and abscess is largely from the front. Thus, anterior decompression is justifiable in the presence of healthy posterior elements. The dorsal spine can be approached anteriorly either by thoracotomy, transthoracic, or transpleural. For anterior instrumentation, the mean of 18 degree of kyphosis correction was achieved. In another study, kyphotic deformity was corrected by an average of 16 degree using anterior instrumentation and fusion. And in the follow-up period, correction loss was about 1 degree. The advantage of anterior instrumentation: both instrumentation and grafting are done as a single-stage surgery through the same incision, thus minimizes the total blood loss and surgery time without much risk of the grafting slipping out due to turning of the patient for posterior instrumentation. This approach prevents fusing an unnecessary large number of level-saving segments. This picture illustrates the anterior approach used for decompression and cage insertion. There is an anterior defect, and the cage and autograft are inserted to fill the gap or defect. Disadvantage of anterior decompression: can be used only in a short segment disease. In mild to moderate kyphosis, that means it needs healthy vertebral bodies above and below the disease segment for a good purchase. The disease affects the anterior and middle columns only, and the posterior column is healthy. High risk of post-operative complication, especially once thoracotomy is used in patients with paraplegia where the intercostal muscles are paralyzed with a compromised pulmonary function. This X-ray of AP and lateral radiograph shows postoperatively the position of the cage and the screw position after anterior decompression and anterior instrumentation. For posterior approach and stabilization, posterior instrumented fusion can be done after anterior decompression either as a two-stage or a single-stage procedure. The cord can be decompressed by posterior, posterolateral, or transpedicular approach, along with the posterior stabilization or instrumentation. The advent of pedicle screw instrumentation and the development of the extended posterior approaches has allowed the surgeon to perform anterior debridement and reconstruction from behind. Thus, surgeons opted for posterior-only surgery. It avoids the hazards of violating the thoracic or abdominal cavities. So the next question is, anterior or posterior approach? It is still debatable. Study by Zhang Heqiu et al. 2012, whereby they did a comparative study of surgical management by the posterior only and combined posterior and anterior approaches for thoracic spinal tuberculosis in the elderly. They concluded that the posterior-only procedure obtained better clinical outcomes than combined posterior and anterior surgeries. But still, it is based on surgeon preference. Zhang et al. 2012 also studied the anterior and posterior approach in the treatment of thoracic and thoracolumbar tuberculosis. The approaches were comparable in regards to duration of surgery, blood loss, fusion, and functional outcomes, but the posterior approaches was associated with significantly better kyphosis correction when compared to the anterior approach. This figure shows a X-ray lateral view. You can see there's a fusion at the T12 lesion and there is a 60 degrees of kyphosis prior to surgical correction. This is a post-op check X-ray. You can see the kyphosis is better corrected with the posterior instrumentation. For vertebral column resection in spinal tuberculosis, continuous destruction of the anterior column and progressive anterior collapse of the spine despite anti-tuberculosis results in kyphosis. Rajasekaran et al. 2001 noticed that children kyphosis progresses rapidly in almost 40% of cases. But in adult, after healing of the spinal infection, the kyphosis usually is static. Angular kyphosis secondary to tuberculosis may progress even after healing, and this may lead to sagittal plane imbalance, cardiopulmonary compromise, and late onset paraplegia. Fixed angular deformity in the sagittal plane resulting from healed tuberculosis requires a 3-column osteotomy for adequate restoration of sagittal balance. The example is posterior only vertebral column resection PVCR. Vertebral column resection is an osteotomy that destabilizes the vertebral column. It is a technically challenging procedure. The complication rate can be as high as 40%, which include dural tear, neurological deficit, either temporary or permanent, and lung-related complications apart from prolonged operation time and blood loss. The authors recommended this surgical procedure only for severe kyphosis, either in active or healed disease. The current trend for minimally invasive spine surgery in spinal tuberculosis. Either we can use 1. Thoracoscopic decompression and anterior instrumentation. It is a video-assisted thoracoscopic surgery (VATS) that was developed to decrease the morbidity associated with thoracotomy. It has a good clinical, neurological outcome, and fusion has been reported in tubercular spondylitis. Number 2, percutaneous pedicle screw fixation and posterolateral decompression using a tubular or mini open retractor system. Yay, we have reached to the end of this video. See you in the next one. Take care and bye.